techniques. I think this is a nice stepping off point after the talk on evaluating new technologies and devices, because it's an area where there's a lot of innovation. There are devices that have some particular nuances that are different technical characteristics. And John, I'm really fascinated to know what's the right one to choose.
Well, thanks very much, Dave, and thanks for allowing me to follow a talk on erectile dysfunction. I will state right up front that this talk is rated G, approved for all audiences, and there won't be any pictures like you saw with Jason's talk. So we're going to talk about atherectomy, and Dave gave me a bit of a pass because he asked me to talk specifically about the devices, the unique features of these devices, the places where they may or may not be helpful, and some of the techniques that will help us optimize outcomes with these devices. And as we treat more and more complex disease, we see more and more patients with critical limb ischemia, multi-level disease. We're trying to treat them without surgery if possible. I think these devices become increasingly helpful for some of the very complex lesion subsets that we're taking on. There's 5 devices available, and we'll talk about each of them. I probably have the greatest experience with laser angioplasty. It's been around for a long time. It's had a bit of a checkered past. I think there was initially a lot of excitement. Perhaps the opportunity to wear these sexy glasses was what got people interested. This is actually Barry Katzen in the early years and Mike Dake when they're very young, when laser was first being evaluated back in the 1980s. And with excimer laser technology, I think we've learned that this approach and this technology can be helpful for complex lesion subsets. I think relative to some of the other atherectomy devices, it's easy to use. It's been shown in at least one randomized study to result in less distal embolization than balloon angioplasty alone for long SFA occlusions. It can be used to help in the crossing of some difficult occlusions using the step-by-step technique, and it can simplify complex anatomy. The laser is effective in deblating or debulking thrombus. It can help with long occlusions and diffuse disease, in many cases providing better angiographic results than if we just use balloon angioplasty alone. So this is a typical case where we would have liked to use laser over the years, 30 centimeter occlusion of the superficial femoral artery from the origin down to the adductor canal. We use the laser first to help us penetrate the occlusion with a step-by-step technique, and then debulked the SFA with actually a pretty nice result with a couple passes with a 2.5 millimeter laser catheter. And then with adjunctive balloon angioplasty, you get a very nice angiographic result without having to lay down 20 or 30 centimeters of metal in that SFA. So this is one of the places where I think this technology can be helpful. And there has been a significant evolution in the devices over the years. The first peripheral catheters were actually approved by the FDA a little over 6 years ago, the 2.3 and 2.5 millimeter over-the-wire catheters. There have been a number of design iterations designed to try and improve the amount of debulking that could be achieved with these catheters, including the first extreme catheter, then the optimally spaced catheter, and then subsequent to that to the turbo catheter. But basically all of these catheters were limited by the fact that you could only create a channel roughly about the size of the catheter, so maybe a 2.5 millimeter lumen at best with the largest peripheral catheter. So SpectronX ultimately developed a turbo booster sheath to allow us to try and create greater lumen sizes with the use of the laser catheter and an eccentric sheath that it could be mounted on, so that you could do eccentric or you could do circumferential directed lasing or atherectomy, much like has been done over the years with the excisional atherectomy systems. The first generation of this was the turbo booster system. The most recent iteration and improvement in the design is the turbo tandem system. And this is just an example of a case treated with the turbo booster, showing the kind of debulking that can be achieved with this circumferential laser ablation. Relatively short occlusion of the distal superficial femoral artery, proximal popliteal artery. The first step is to create a pilot channel with that laser catheter, the over-the-wire 2 mm catheter, and we can see that, again, you get a relatively small lumen about the size of the catheter when you create that pilot channel. Then you take that 2 mm laser catheter mounted on the turbo booster, the turbo tandem sheath, and you can then do your directional debulking in the SFA. And this is the type of lumen that can be created when you do that. Here now we have a 3 to 4 mm lumen compared to that small 2 mm or less lumen. Looks pretty good angiographically, a little bit shaggy, and after adjunctive balloon dilatation we see a cleaner, nicer angiographic result and additional improvement in that luminal diameter and cross-sectional area. So it's been shown well with this catheter that you can achieve better debulking with circumferential laser atherectomy, although there has not been a lot of work in terms of longer-term outcomes and whether that initial better result equates to improved clinical and patency outcomes. Another area where laser has been helpful over the years is in the treatment of critical limb ischemia. We published a paper now about 5 years ago looking at a large multi-center prospective registry of laser-assisted angioplasty for patients with CLI. Ultimately included 145 patients, 155 limbs, with really quite good clinical outcomes in that trial. Limb salvage rate at 6 months of 93%. And the real value proposition, I think, for laser in these types of patients is for the long occlusion, the very diffusely diseased tibial artery, the types of cases that we often see in our CLI patient population. A case like this where you see diffuse disease of the perineal artery, long total occlusion of the anterior tibial artery, a long occlusion of the posterior tibial artery. It looks like there might be a decent dorsalis pedis reconstituted at the foot. With the laser-assisted angioplasty of both the perineal artery and the anterior tibial artery, we see very nice angiographic result now with a dramatically improved flow into the foot. It's not the focal lesion, it's not the short occlusion, I think, where the laser really helps. It's for these long occlusions, very diffuse disease, in conjunction with balloon angioplasty. I think we get a little bit better angiographic and hemodynamic result, which could equate to better limb salvage rates in the longer term. Technique is important, I think, with laser. This is a contact laser, so you really have to be right up against the plaque to ablate it. If you advance the catheter too fast, you're basically just doddering. You're not really ablating the tissue. So if you really want to get effective debulking, you have to advance the catheter very slowly, less than 1 mm per second. We showed a long time ago in the coronary arteries that saline flush was very important. You don't want to activate the laser in the presence of contrast because it creates little micro explosions that can increase the risk for dissection. And it's better, if you can, to flush blood out of the field too, so just to laze in the setting of saline. I've found over the years that if you go to the higher energies, you're going to have higher complication rates, higher perforation and dissection rates. So I only use the higher energies when we have a very calcified lesion or have inability to cross the lesion with the laser. Appropriate catheter size is important, particularly when you're lasing in the infrapopliteal vessels. You don't really want to match the laser catheter to the vessel diameter. You want to go about 60% of the size of the tibial artery to achieve a good lumen, but not to have a greater risk of perforation. And ideally, much like with some of the rotational atherectomy techniques, you'd like to have runs of less than 30 seconds to allow for heat dissipation, some flow in the vessel, and less potential for particulate embolization. So where do we think laser may play a role? I think for the diffusely diseased vessel, the long occlusion, perhaps in vessels where you don't want to lay down a lot of metal. We have found it useful over the years for in-stent restenosis. Because the laser can debulk thrombus, it can be used in thrombotic lesions with a potentially lower risk of embolization. And as we talked about for the CLI patients who have very unfavorable anatomy for the typical angioplasty techniques that we use. Lou talked a little bit about excisional atherectomy, including a brief history of the Simpson atherectomy catheter shown here. There's been tremendous evolution in the devices over the years. The initial device had a balloon on it, so it caused some barrel trauma, had a relatively limited cut length of around 15 millimeters, making it very impractical for peripheral arterial use, a different cutter, different RPMs. The newer devices allow us to treat a disease in the peripheral circulation much more easily. And there has been incredible iterations in these devices over time. The latest version of the excisional atherectomy catheter, the TurboHawk catheter, is much more effective for debulking very heavily calcified lesions and can really allow us to take on cases that in the past we probably wouldn't have considered taking on. Some of the iterational improvements include a better drive shaft for more efficient cutting, improved jog for a wider treatment range, allowing you to debulk better in larger vessels, and MEC technology allows us to pack more material into that nose cone, so you don't have to keep taking the catheter out and cleaning out the nose cone and reinserting it. And as we talked about with the TurboHawk calcium cutter device, a super cutter device, we now have a device that's really quite effective for bulky calcified lesions. This is a typical kind of case where I would be thinking about using excisional atherectomy. Patient who'd had 2 prior FemPop bypasses, came back in with ischemic rest pain, had subtotal occlusion of the common femoral artery, very scarred up femoral region. This was treated successfully with excisional atherectomy with a very nice angiographic and hemodynamic result. It's a little bit complicated in terms of the number of devices. It requires a fairly significant inventory in the cath lab or your endovascular suite. But to try and distill it down a little bit, I think for the above knee, we like to use the L series catheters, both the calcium cutting catheters, short and longer nose cone, and the smooth cutting catheters, short and long nose cone. And then below knee, really stick to the SXL and the EXL catheters that have the longer nose cone for better capture of plaque material. From a technique standpoint, I think it is important when you're making passes and treating longer lesions to not make a pass longer than the distance of the nose cone to try and reduce the potential for embolization. To make circumferential cuts, ideally we like to be somewhat controlled when we do that, and if you rotate the directional device, each click corresponds to about 10 degrees, so you can be somewhat precise when you're doing your circumferential cutting. You want to be careful not to keep going around in the same direction because you will wrap the wire and have trouble then getting the device out without taking the wire with it. Shallower cuts for in-stent restenosis or calcified plaque I think is important, particularly if you're in a stent. You don't want to get caught on the stent struts and then potentially have a difficult situation to bail out from. These are the actual cutter depths. So for calcified lesions or for in-stent restenosis, we tend to use the M series cutter or the calcium cutter. And then for the below knee devices, they have a 8/1000 cut depth. And if you're going to be using these devices for really complex lesions, calcified lesions, using the TurboHawk catheter, really need to have an embolic protection device in place because you are going to see embolic debris when you use these technologies. So this is an off-label use of the excisional atherectomy catheter, a case of in-stent restenosis, treated with the M-series atherectomy catheter. See after debulking a pretty nice angiographic result. The kind of material that you can achieve. We did use embolic protection in this case, and you can see actually that there is some material that was captured in the tip of the spider embolic protection device. So what do we do with this material when we retrieve it? Well, there's a lot of creative things to do with it. This was clearly a nurse who had too much time on her hands. You can send it off to the lab for a pathologic review, although I often find that not too helpful when you get a path report coming back saying atherosclerotic plaque or neointimal tissue. So in this case, we went back also and did balloon angioplasty with the angioslide balloon with a typical nice angiographic result that you see when you debulk first in these in-stent restenosis lesions. So where do we like plaque excision? I think places where you don't want to stent, heavily calcified lesions like we talked about, in-stent restenosis, osteal lesions, eccentric lesions where balloon angioplasty doesn't work well, And in the future, there may be a role for these technologies prior to drug-eluting balloons to really try and achieve the very best long-term patency. One of the other devices that's commercially available now is the orbital atherectomy system from Cardiovascular System, CSI, the Diamondback or Predator system. This works on the principle of centrifugal force. You have an eccentrically mounted crown that when you rotate it and rotate it with increasing speeds, the centrifugal force presses this eccentrically mounted diamond-coated crown against the stenotic lesion, removing that thin layer of plaque, basically sanding that lesion down to improve the luminal area. And you can increase the amount of debulking and lumen size by increasing the speed of the rotation of this eccentric crown. Unlike the rotablator, where you basically get one lumen size per burr, here you can basically achieve better luminal gain and better outcomes with just one device. And there have been a number of iterations over the years of this technology. It was a little confusing for a while because we had the classic crown, the solid crown, 30 grit, 70 grit. It's been simplified now with the Predator 360-degree solid crown with some improvements which we'll talk about with that device. And then a classic crown is still available for some cases. This is a little bit more aggressive in terms of the debulking or the sanding that you see. This is a little bit more conservative, potentially could be used in cases where you don't have as good infrapopliteal runoff, or in places such as osteal lesions or in bends where there might be a slightly higher risk of complications. This is the Predator device. Been some changes in the crown configuration. You can see it looks a little bit like sandpaper because that's basically what it is. It's a device that's designed to sand down the lesion, there's now a smaller diameter Predator device which can be helpful for infrapopliteal use or for creating a pilot channel in long total occlusions. Over the years, I think the concept has evolved a little bit with regards to orbital atherectomy. I think we don't try and achieve a standalone result anymore with large burrs going to high speed rotation. Particularly with the Predator, we're a little bit more conservative, use the lower speeds, smaller burrs, try and change the compliance of the lesion, debulk the lesion, and then follow it with a prolonged low pressure balloon inflation to optimize the results. So this is the kind of case where we'd be thinking about this technology: heavily calcified lesion, coral reef calcification in the popliteal artery, debulked in this case with a 2.25 millimeter crown at lower speed with low pressure balloon inflation afterwards with a nice angiographic result. This is a case that I did with Darren Klaus, heavily calcified lesion in the mid-SFA with bulky exophytic plaque. After again a 2.25 millimeter crown, lower speed, and balloon angioplasty, a nice result. So this is a lesion that works very well for heavily calcified lesions. We use it a lot like we use the rotablator in the coronary arteries, just pecking, slow advancement of the catheter through the lesions. You don't do long runs. You don't aggressively push the burr into the calcified lesions. Very gentle technique. Shorter runs again to allow for heat dissipation, but also allow for the particulate to wash off. There are some important things to keep in mind in terms of safety. You never want to advance the crown by advancing the sheath on the shaft of the device. Never force the crown when resistance occurs. Again, it's a gentle pecking motion. If you hear the RPMs drop and you back off out of the lesion. We do not allow the crown to rotate in one spot for more than 2 to 3 seconds. We don't want to have really long runs with high speeds because that can create more particulate, but also can create hemolysis in some cases. And obviously we don't want to activate the crown while in the sheath and potentially debulk the sheath and create plastic particulate into the distal vasculature. And we do have to be cognizant. You don't want to be ablating over a kinked wire or a sticky wire because there's potential for the device to get stuck on that wire. But it's a very effective technology for really extremely calcified lesions and a useful addition to the toolkit. Just very briefly at the end, I'll mention the other commercially available atherectomy device, which I don't have any personal experience with, the Pathway Jetstream G3 system. The interesting feature of this device is that it you can achieve larger lumens by spinning the catheter in different directions. When you spin it in one direction with the blades down, you can create a 2.1 millimeter channel, then spin the other direction with the blades up, create a larger lumen with up to 3 millimeters in diameter. It will go over a 14 thousandths wire through a 7 French sheath. The other unique feature about this device is that it has aspiration as a part of the technology. It's the only atherectomy device where you actually can aspirate some of the particulate and potentially reduce the risk for distal embolization. It now comes in a smaller size as well for infrapopliteal use, the Jetstream G3SF catheter, a 1.85 millimeter diameter. As we talked about, has aspiration as part of the procedure, potentially minimizing the risk of distal embolization by a continuous removal of debris during the atherectomy procedure. It's been promoted as a technology that can be effective in all plaque morphologies, hard and soft plaque, calcified plaque, thrombus containing lesions, and fibrotic lesions, although I think it remains to be seen whether this device will be as effective as the Predator Diamondback system or the TurboHawk system in those extremely calcified, bulky coral reef type plaques. So I'll conclude by saying that there has been, continued evolution of these devices, as well as evolution of the techniques where we use these devices, and it does allow, I think, for a better treatment of very complex lesions, some of the very difficult patients that we see nowadays with multi-level disease, calcified lesions, critical limb ischemia. There are clear differences amongst these devices. I think they work better in different lesion subsets. For the really extremely calcified lesions, I think TurboHawk Calcium Cutter and the Diamondback Predator, I think, are very nice devices. For thrombus-containing lesions, softer lesions, I think Excimer Laser, Pathway, Jetstream are very effective and useful technologies. But clearly we need more data about these devices. We need some comparative data and data that will help us to decide where and when to use these technologies. Thank you very much.
And techniques. I think this is a nice stepping off point after the talk on evaluating new technologies and devices, because
treat them without surgery if possible. I think these devices become increasingly helpful for some of the very complex lesion subsets that we're taking on. There's 5 devices available, and we'll talk about each of them. I probably have the greatest experience with laser angioplasty. It's been around for a long time. It's had a bit of a checkered past. I think there was initially a lot of excitement. Perhaps the opportunity to wear these sexy glasses was what got people interested. This is actually Barry Katzen in the early years and Mike Dake when they're very young, when laser was first being evaluated back in the 1980s. And with excimer laser technology, I think we've learned that this approach and this technology can be helpful for complex lesion subsets. I think relative to some of the other atherectomy.
It's an area where there's a lot of innovation. There are devices that have some particular nuances that are different technical characteristics. And John, I'm really fascinated to know what's the right one to choose.
Well, thanks very much, Dave, and thanks for allowing me to follow a talk on erectile dysfunction. I will state right up front that this talk is rated G, approved for all audiences, and there won't be any pictures like you saw with Jason's talk. So we're going to talk about atherectomy, and Dave gave me a bit of a pass because he asked me to talk specifically about the devices, the unique features of these devices, the places where they may or may not be helpful, and some of the techniques that will help us optimize outcomes with these devices. And as we treat more and more complex disease, we see more and more patients with critical limb ischemia, multi-level disease. We're trying to